All right, I believe those who've RSVP'd have all signed in. So thank you so much for following the ability to log in with these multiple sessions. Good morning, everyone. Please welcome to our first breakout session. The topic is Act Rapidly to Treat Uncontrolled High Blood Pressure. If this is not the breakout session that you were looking for, please message the panelists in the chat box so we can help you get to the right place. While we wait for folks to switch, we just want to hear from you. In that chat box, much like you did in the opening session, just put in where you're from and what agency or what part of the country you're visiting us from today. But as you do, please make sure to select all panelists and attendees from that drop down in the chat so we can see, so that all can see where people are joining from. You could also use the chat box to ask questions throughout the session, and we will get to those during the Q&A portion of today's breakout. During our Q&A, to ask questions, please raise your hand using the icon at the bottom of your screen. We will work to unmute you for your question and then remute you afterwards. Now, please, fresh from our opening program, welcome Vice President of Health Outcomes at the AMA, Dr. Michael Raycotts.
Thank you, Franklin, and thank you, everyone. Can you hear me okay?
Yes, we can, and we can see your screen. Thank you.
Okay, excellent. So I hope this isn't going to be too much back to back this morning, but I'm really excited for this session because this, I think, is it takes a little bit of a deeper dive into something that I am extremely passionate about, and I think is really our best path forward to improving blood pressure control, and that's acting rapidly to reduce therapeutic inertia and improve treatment intensification in people with hypertension. So this is something that, again, I talk about all the time, and I think it's extremely important, and hopefully you'll find it interesting. Again, don't hesitate to put questions in the chat that we'll get to in about 30 minutes, and we should have about a 15-minute Q&A at that time. Which should be great, and maybe even we can get you off of mute to ask some questions if we have time and that's possible. So the objectives, we're going to talk about therapeutic inertia, define it, talk about contributing factors, discuss the impact of treatment intensification on blood pressure control, and how to do that, some strategies that clinical care teams can use, really practical suggestions for doing this in the real world to improve blood pressure control. So let's start with the impact of treatment intensification on blood pressure control compared to some of the other major key components of uncontrolled high blood pressure. This is a really important study, I think, from Brandon Bellas and colleagues from Columbia. And this study, really important study. So the three of the main key drivers of blood pressure control are medication adherence, medication intensification, and interval to follow up for people with high blood pressure. And what this study did was it used clinical trial data and real world data to model what would happen, where are we currently with these three key areas, and what would happen if we optimized each one to perfect state? What would the impact be on blood pressure control? We hear a lot from providers across the country, and I'm a family physician. I have felt this way at times that the main reason that we can't get people to goal is that they're not taking their medication. While that's an important factor, I think you'll see shortly it may not be the most important factor. Of course, we want all of our patients adhering to treatment plans and taking medications as recommended. But we see here that about 50% of the time at 1 year, people are taking their antihypertensive medication as prescribed. We see that follow-up time between visits for people who are uncontrolled is about 14 weeks, even though the recommendation most commonly is about 4 weeks. 14 weeks between visits for people who have uncontrolled high blood pressure. That's the national average. And that blood pressure medication is intensified at about 13% of visits when somebody has an uncontrolled high blood pressure. In other words, it takes about 7 visits for somebody to get a treatment intensification when their blood pressure is uncontrolled, which is a pretty amazing statistic. I can say that we have validated that number in 1.7 million patients in the real world and found it to actually be closer to 12% than 13%. So this, the data presented here are extremely accurate, and I think it's impressive that they modeled this. So why is that important? Well, let me tell you that if we assume a blood pressure control rate of 45.6%, which is what they did in this model, which is actually very close to the national average, which is about 44% right now, they thought about what would happen if we could improve adherence to to 100%? What would happen to blood pressure control rate? And it turns out if you do that, if you model everybody taking all of their medication for hypertension, blood pressure control would go up significantly to about 57% control to 45.6%. I think it would be nice if that was a much higher number, but that's you get about 11.5% increase in blood pressure control. And what about if you increased follow-up time from 14 weeks to every single week? What would be the difference there? And of course, if you're seeing people every week, you'd see a larger number get to goal. About 67.6% would achieve goal blood pressure. But of course, we know that that's not very realistic, and it's not going to happen seeing people back weekly until they're controlled. But even if you did that, that's the impact that you would have. So a little over 20% improvement in blood pressure control. But to me, this is the most, yes.
May I just interrupt? We're trying to turn your camera on from the back end, but we're having trouble. Are you able to turn your camera on from your end?
No.
Okay, we will keep working on it.
It just says, I get a message that says the host has stopped it. So just FYI.
Okay, thank you.
Okay, no problem. So I think here's the really important part of this slide is that if you independently increase the probability of intensifying to most of the time from 13%, so about 62% of the time, regardless of what people were on prior to that intensification, you would achieve over the next 1 to 2 years across a large population or nationally greater than 80% blood pressure control from 45%. So clearly, I mean, this is the most impactful of any of these three key drivers of blood pressure control. I mean, by far, really. And this is one of the reasons that we focus so much on improving treatment intensification, why we're talking about it for such a concentrated amount of time today. So let's talk a little bit more about intensifying treatment. Again, takeaway number one, this intervention would have the greatest impact on improving blood pressure control. I have a few takeaways that I threw in here because I think they're so important. They're worth repeating several times, which I've already done, and I'll continue to do. So let's define therapeutic inertia and talk about how we can reduce it. So therapeutic inertia, by definition, is a lack of treatment intensification when a patient's blood pressure is high. And there are a lot of reasons this occurs. There are system factors and provider factors and patient factors. But one of the phenomena that we see most often that has actually been studied is that healthcare providers in general, prescribers of medications, often overestimate the quality and aggressiveness of care they're providing for people with high blood pressure. It's hard to explain that phenomena. But it happens all the time, and it's something that we need to combat. And this is where having the data really, really helps shine a light on what's happening and what isn't happening. There's also a lack of training based on current evidence. There's often guideline confusion from that evidence, but most people learn how to manage hypertension from another person. So it's peer-to-peer. It's usually done in residency training, and it's not, it's not always the highest quality training for hypertension for some reason. But most people that when we query them and ask them where they learn to manage patients with hypertension, there is no course on hypertension in most medical schools. It's really something that you learn after you complete your undergraduate medical education. Also, this is another thing that's been studied, is the use of soft reasons to avoid intensification. And these are things that we all hear every day in practice, things like, well, I just had a cup of coffee on the way in, or I just smoked a cigarette before I came in, or I'm having a rough day at work, or the provider's extremely busy and maybe doesn't have time to take in all of the information. And there are, and probably the most important one here would be that providers don't always trust the quality of the blood pressure assessment that's done, whether it's out of the office or in the office. And as a result of that, they're not sure. They're seeing inconsistencies between in and out of the office, not sure what to do with that, aren't really formally assessing that using an evidence-based protocol. So that leaves doubt in whether or not somebody actually needs an intensification. And we know providers don't want to add pile-on medication for patients, and patients don't want to have more medications added to their regimen. So this creates, we talk about the concept of shared decisions. It's challenging. to get everybody on the same page here and understand the importance of controlling high blood pressure. Medications, again, the most significant impact. And of course, all of the lifestyle changes that can be made in promoting healthy lifestyle is extremely important. And that's assumed in all of these cases. But again, it's very hard to do and be effective doing that in a clinical setting. It doesn't mean we won't try, but we need a combination of pharmacologic and non-pharmacological therapy to try to move the needle on blood pressure control. And there are concerns about costs. I already mentioned guideline confusion, but these are some of the reasons why therapeutic inertia is such a big problem. So how can we overcome it? So we have a very straightforward approach using a three-pronged approach here. We love the idea of using single pill combination medications. We'll talk about that in detail. Treatment protocols are very important for a team-based approach and following up frequently until control is achieved. So let's talk a little bit more about the use of single pill combination therapy and just combination therapy in general. I already mentioned that twice today that most people will need 2 or more medications to achieve their blood pressure goal. And this is a concept that I think when we were all trained in managing people with high blood pressure and in many guidelines in the past, the idea of stepwise therapy, start a medication, whether it's a low dose or a standard dose. If somebody's uncontrolled, increase it. And if they're uncontrolled, increase it again. And we go through many steps of this before adding the next medication. And this is a problem for many reasons. You get a lot more blood pressure lowering by adding a new medication class, even at low dose, actually 3 times more blood pressure lowering power than increasing or doubling the dose of a current medication. And, this is an extremely important concept to remember. I call it the 7-9-11 rule. If you use a low dose of a medication on average across drug classes, you'll see about a 7 millimeter reduction in systolic blood pressure. If you double that medication, you'll get about an additional 2 to 3 millimeter drop in blood pressure. So 2 millimeters compared to 7 millimeters by doubling the medication of benefit is much lower than another 7 adding a low dose additional class. So if you use a low dose, you'll see about 7 millimeters of reduction in systolic BP. If you use a standard dose, it's about 9 millimeters. And if you use high dose or double it again, you'll get an additional 2 millimeter drop. This is on average, but I think this is a very important point to remember, that you'll get a lot more blood pressure lowering if you add a drug class than if you merely increase the dose. And this is really, really important because, again, I already talked about that it's, you have to have 7 visits on average in the United States to get an intensification, and there's 14 weeks between visits. And so if we're using a multi-step process before we get to the next medication, this is why it takes years and years to get people to goal. And often it doesn't happen because we're just titrating doses rather than adding drug classes. So take home number 2, when you're intensifying treatment, adding a new medication class is 3 times more effective at reducing blood pressure than increasing the dose of an existing medication. And that is not intuitive, I think, for a lot of people, but it's a paradigm shift we need to make if we're going to improve blood pressure control. And this is looking at the 2017 guideline. And I think a point that's often missed, this is the ACC-AHA guideline in 2017, the latest US guideline for diagnosing and treating high blood pressure. And I think what's important here is there's a 1C expert opinion recommendation to initiate therapy with 2 drugs if the blood pressure is greater than 20/10 from target. But I think what's often missed as a guideline recommendation here is an even stronger level of evidence that talks about the importance of, for people with blood pressure greater than 140/90, so stage 2 hypertension as defined in the guideline, if people are uncontrolled, they need to be followed up monthly and have a combination of non-pharmacologic and pharmacological therapy. And if pharmacological therapy is used here, 2 agents of different classes are initiated and reevaluated in 1 month. And I think even if you're not 20/10, the idea of using 2 meds instead of 1, even at lower dose, so that you don't overtreat, is really important and has significant benefits that I'll talk about right now. The European Society of Hypertension and the European Society of Cardiology feels the same way. They have been recommending since their guideline in 2018 that most patients go on dual combination therapy as initial therapy, and they have a combination strategy approach for 2 pill combinations and 3 pill combinations as the first 2 steps in treating people with high blood pressure. There are a lot more 3 drug combinations available in Europe than in the United States, but we're hoping to see more here soon. So this is an important study it was actually a study done in Europe and Italy, looking at tens of thousands of patients, and they compared people who were started on monotherapy versus combination therapy for uncontrolled high blood pressure. And what they found was that if we'll just look at the box in the lower right hand corner, if you compare those that were started on monotherapy at the start to 3 years later, what you see is that a majority, almost 2/3 of the people started on monotherapy remained on monotherapy 3 years later. And for those that were started on combination therapy, about 80% of those remained on 2 or more medications 3 years later. So well tolerated, and there are some benefits here. But I think the takeaway here is often what people are initiated on, they stay on. If they're initiated on one drug, they stay on one drug 3 years later, and often indefinitely. And these are, whether they're controlled or not, if they're started on combination therapy, they typically remain on combination therapy. It's well tolerated, it's effective. So I think this is an important point of large real world data that make a really important point. And I think probably an even more important point, when they took those same people and followed them over 3 years, the red box is the reference standard here of being on one drug, and they compared hard outcomes for people who are on one drug versus combination therapy initially. And what you see is across the board reduction in cardiovascular events. So any cardiovascular event, there was a 16% reduction in those that were initiated on combination compared to monotherapy. Heart failure, a 35% reduction. Cerebrovascular disease, 15% reduction. Ischemic heart disease, 20% reduction. I think very surprisingly, a 20% reduction in premature death in those that were started on combination versus monotherapy, regardless of dosing. So there are actually improved outcomes for people if you could start them on 2 medications compared to 1 and not overtreat them. But in all cases here, there were benefits across the board, overall. So I think this is an important point to consider. So the advantages of single pill combinations, they obviously, studies have shown they lower blood pressure more effectively and help people get to goal faster. They improve adherence, medication adherence compared to using multiple pills. They reduce adverse effects if lower dose are used compared to a single drug at high dose. And there really are, I think what's important here is that there are no more discontinuations using combination therapy compared to monotherapy. That's been well studied. And there are, surprisingly, I think we hear all the time when we in our work in health centers that a lot of providers aren't aware of all of the options for combination therapies that are available on Medicaid and 340B formularies in those health center settings. And there are 2 and even 3 drug combinations available, many that don't require prior authorizations, that are extremely low cost. And it's just, I think we just need to continue to talk about this to make sure that people are getting the treatment that they need to get to goal. When we look at patterns of prescribing, this is data from 2018 that was recently published, and it really looked at the top 200 medications prescribed for cardiovascular disease. When you look at the subset for hypertension specifically, no surprise, lisinopril was the most commonly prescribed medication, almost 100 million total prescriptions in 2018. And when you look across the top 10, one single pill combination cracks the top 10, and that's lisinopril HCTZ, lisinopril hydrochlorothiazide combo. But it's the fact that it's the 9th drug, most frequently prescribed drug. When you look at a place like Kaiser, where it's emphasized as the first drug in across their population, you see Kaiser's at a 90% control rate for many reasons. But I think this is a big part, and they think that this is a big part for why they have such high control rates, is their treatment protocol recommending a combination therapy from day 1 for people with uncontrolled high blood pressure. All right, so take home number 3, initiating treatment with 2 medications at low to standard dose is more effective at reducing blood pressure and gets people to goal quicker and can have less adverse effects. So let's move now off of single pill combination therapy and talk a little bit about using a treatment protocol. And I don't have a lot of slides here to talk about, the importance of using treatment protocols. But one of the things that's really nice is we say all the time that it's like a playbook for the whole care team, for a team-based approach, that everybody knows who needs treatment, what treatment they need, and when they need follow-up. So follow-up's really critical here. People should be seen every 2 to 4 weeks based on the evidence after a treatment intensification occurs, or from a time that their blood pressure is assessed and they're uncontrolled until their blood pressure control is achieved. I told you that the average across the United States currently is estimated to be about 14 weeks between visits for people who are uncontrolled, and not 4 weeks. So this is something that's absolutely critical, and a treatment protocol can really help everybody understand whether or not a follow-up appointment's been made, and whether it's an appointment to do this in person, whether it's a free MA check or RN blood pressure check, or whether this involves using out-of-office measurements. I think that's really an important component here. So that's really what I wanted to touch on, and I think that I think that some of my slides got lost in the process here, but I think those are really the most important points that I want to make. And I just want to, I know I'm covering a lot of information here, but I just want to review just all of this in the context of really what are some practical suggestions for reducing therapeutic inertia and obtaining blood pressure control more quickly. And I mentioned earlier that one of the leading drivers of the lack of intensification is this clinical uncertainty around what is the true blood pressure. And so we spend a lot of time focusing on accuracy and reliability of blood pressures measured in clinical settings to make sure that they're representative of what the patient's blood pressure would be when they're not in the clinical setting. So it tends to be focused on high quality measurements using a measurement protocol, so everybody knows how much rest, how many measurements, what devices to use, making sure that those devices have been checked for accuracy. So calibrating the devices at frequent intervals, depending on the type of device. If it's a portable manual device, those devices that are cuffs with little Android dials attached to them that are portable, those devices need frequent calibration. Actually, the recommendation is to have those calibrated every 2 to 4 weeks, because even just setting that down on a counter can cause them to come out of calibration and be very inaccurate. And we've yet to see an office anywhere in the country that uses portable aneroids that actually checks them at all. In most biomed groups and health centers and health systems check devices about once a year, and they typically look for cracks in tubing and leaks. They don't actually check the devices for accuracy. Some do, but even when they do, they rarely check the portable devices. So I mention this because I think it's really important. There's a 2018 or 2019 scientific statement from the American Heart Association. It's 2019 on blood pressure measurement and how to measure accurately, how to check calibration. Really important guidance there. And I also want to emphasize the use of out-of-office measurements or self-measured blood pressure monitoring. A lot of benefits here, but as I mentioned in the first talk this morning, it's not always done in a way that it will actually improve blood pressure control. There's no magic for people having devices at home and improving their blood pressure control. That's not going to happen unless some very specific things happen. So self-measured blood pressure monitoring needs to, training on how to use the device needs to happen from a healthcare professional for it to be effective. Typically, an evidence-based measurement protocol needs to be used. So how many readings? Typically, if you're assessing BP control over the period of a week's time, which is recommended, 2 blood pressures measured a minute apart in the morning and evening for 7 days, and those blood pressures averaged with a minimum required of 12 readings over that 7-day period to qualify as giving you enough measurements to average and then determine whether or not the blood pressure is controlled. And just a reminder there on self-measured blood pressure monitoring, if there are typically, if you're using 140/90 as goal blood pressure in the office setting, that translates to 135/85 in the home setting. This is clearly reviewed in both the scientific statement on blood pressure measurement and the 2017 guideline. And in most guidelines around the world, it's the same. So if you're looking at averages of out-of-office measurement to assess blood pressure control or using out-of-office measurement, you need to average measurements over a period of a week, minimum of 12, and 135/85 is the cutoff for blood pressure control if you're using 140/90 in the office. And the reason for that is that organ damage in the office starts at 140/90, and at home, organ damage starts, hypertension mediated organ damage starts at 135 systolic and 85 diastolic. So that's the why there, and I'm happy to discuss that in more detail. And again, like I mentioned in my talk earlier this morning, the importance of having relevant, timely education and data, patient data brought to the point of care is extremely helpful. Again, there's a lot of resistance from physicians and other providers on how well they're doing, and sort of a disbelief that they're not doing a great job at this for blood pressure control. And having that data really helps them identify what some of their gaps are in blood pressure control. So it's extremely important to try, whether it's through chart reviews, if you don't have the capability of having registries and dashboards with data to point this out, chart reviews can be a great alternative. As far as treatment protocols go in the real world, I think that it's essential. I think that they are used. We'd love to see when they're used, but when it doesn't always go well, they're not often used if they are given to an organization by another organization. So while we encourage the use of treatment protocols, we like to collaborate and help organizations that want help in creating one, but hopefully they've created their own already with their departments of pharmacy and with primary care providers included. If it's something that's forced on a group of healthcare professionals, it is rarely used as it should be. So engaging people in the process of developing these protocols and disseminating these protocols is absolutely critical. With a team-based approach, we love to see pharmacists involved as early as possible, and all care team members using the protocol really can be effective. I know you know all of this, but our experience has been that taking those protocols and actually even embedding them into EHRs with clinical decision support options, pre-populated preference lists, and order sets can really make a huge difference in changing prescribing behavior and adhering to best practices here. So this is another really critical component. And I mentioned earlier the importance of frequent follow-up, but that doesn't mean somebody has to come in, especially when we're looking, from an equity standpoint. There are a lot of barriers to people being in clinical settings, whether it's transportation, whether it's needing to be at work, and having expanding access to include out-of-office measurements, home blood pressure measurements, in the way that we've talked about that. Can, while there is a concern that there is a digital divide and many people lack the ability to transmit data from home, the fact that if we could increase access of devices so that people could measure their blood pressure at home, we certainly, whether it's through bringing in and dropping off at their convenience, their blood pressure log, phoning in their blood pressure log, or transmitting it electronically, there are a host of options there for getting the data back to the care team so that it can be used to guide management of hypertension is really critical. But the follow-up that I talked about as being 14 weeks, that's typically for in-person follow-up, and it's really hard to do in the real world. And I think, again, with the pandemic, it really exposed that as a major problem for people being able to make it in all the time. And we were really behind on the dissemination of accurate blood pressure measurement devices and the ability to transmit that data or communicate those readings back. So using out-of-office measurements is a really key component. We just have to build the infrastructure out a little more robustly so that everybody has access, or a majority of people have access to do that. And then they can choose. For some people, the in-office visits are more convenient and preferred. And so we've got to respect patient choice there for what they want to do and how they want to do it. I think there's always going to be some combination of in and out of office measurements, but we want people to have the choice to be able to measure out of office and communicate those results rather than having to come in for every single visit, which again is failing with a 14-week interval time. It's just not practical. And again, I mentioned a team-based approach, leveraging community health workers where available. We're studying that all the time, getting pharmacists involved. We're talking to pharmacists weekly now, trying to figure out incentives for primary care teams and pharmacists to collaborate together to improve blood pressure control. And I say this often, that I don't know that I've ever seen a study that included pharmacists co-managing hypertension where it wasn't better than usual care without a pharmacist co-managing hypertension. So we really need to take advantage of that as a resource to improve blood pressure control where available, and then make it so that it's financially feasible to have more availability of pharmacists to do that work by improving reimbursement for pharmacists who are helping manage hypertension. So the final take home here before we get into the discussion, healthcare organizations, care teams, physicians, other providers, a multidisciplinary team-based approach to reducing therapeutic inertia is required, and certainly to improve blood pressure control, it's going to take the entire care team to do that. So that's just a very quick run through, a little bit of a deeper dive into treatment intensification and the importance of that. And I figured this usually, when I give talks like this, there are a lot of questions, and happy to get to questions now. Franklin, I don't know if we want to read questions going in the chat.
Yep, we have a few already in chat and some that came separately. And I'll start with one that dovetails off of your last section, which is, why is therapeutic inertia such a big problem? It seems like it would be easy to solve.
Yeah, and I mentioned earlier, I think there are patient factors, provider factors, and system factors that contribute to therapeutic inertia. So from a provider perspective, just the fact that, I think we can all say as providers, if we had 20 or 30 minutes for every visit, it would be a whole lot easier to address more. But even then, studies have looked at primary care providers and said that in order to meet guideline recommendations and the evidence-based for best practices in care, it would take about 21 hours a day to employ those and take care of people. And that's obviously, it's usually 5 to 6 hours of patient care a day. And much of that time is not spent face-to-face with patients. And so that's a huge gap. And so where providers need to prioritize time, it's challenging. And with electronic health records, vital signs aren't always highlighted. It's easy to miss. And so there are many competing priorities, and depending on the organizational priority for a condition, we see hypertension prioritized at some organizations some years, and diabetes other years, and high cholesterol other years. And while, of course, doctors need to address all of these things, there are a lot of factors there that impact their ability to do the job that they want to do, managing people, especially when they're doing it on their own, and they don't have the ability to have as much of a team-based approach. So there's the provider side of this. From the patient perspective, I mean, there's cost, there's convenience, there's the fact that they don't want to take more medications, who could blame them, and that they don't necessarily have symptoms or feel bad with high blood pressure, and so they're even less likely to want to take more treatment. And then even when it's prescribed, are they adhering to treatment? We showed on the slide that it's about a little over 50% at the first year are taking their medications as recommended. So a lot of challenges there. And when when a provider's not sure about the adherence to treatment, they're much less likely. It just plants that seed of doubt. Maybe they shouldn't increase medication if people aren't taking their current medication. And so that's, these are all common major problems. And from a systems perspective, if you don't have that data in front of you to see that these are real problems and where the problems are, from a system standpoint, if you don't have a treatment protocol, if you don't have a registry, if you don't have metrics available, or, with these patient lists to look at who's controlled and uncontrolled, it just gets harder. So these are all some of the common barriers. And I think that coupling that with the soft reasons that are often used to not intensify treatment, it's not a surprise really. And the fact that again, that we overestimate how good we are at this. So harder to explain why that is so common, but it's extremely common. And again, that's another case for having the data to put in front of providers to actually really turn the lights on for what's happening or what's not happening. Long answer to that question. Sorry about that.
All good, all good. Good information. Attendee Allison Smith, I'm going to allow you to talk and bring you hopefully off mic. If you would be willing to come off mic and ask your question directly, that would be terrific.
I'm happy to. Just a quick, I hope you can hear me. Just a quick question. We get questions about how to focus on diastolic blood pressure lowering uniquely from systolic, and I'm wondering if you have any insights there.
Yeah, I mean, most of the studies looking at increased risk, I mean, they're true for both systolic and diastolic. I think there has been more attention paid to systolic blood pressure for many reasons, including, when you look at the SPRINT study, for example, there's, a large focus on having lower treatment targets for systolic blood pressure. And the benefits that come from that. But it's a really good point from the standpoint. I think we hear more about diastolic blood pressure in going too low that we don't hear in the same way for systolic blood pressure, in that for somebody with known cardiovascular disease and comorbidity, making sure that the diastolic blood pressure stays above 60 millimeters of mercury is really important. And so I think that both are very important that more emphasis is being placed overall on systolic than diastolic for lowering blood pressure when it's above target, but always need to be mindful of how low the diastolic blood pressure is. There's a little bit of a controversy in this. Is there a J-shaped curve phenomena where morbidity and mortality go up with blood pressures below 60? But I don't know that it's as big of a controversy as it used to be. And, the recommendations from experts around the world is that, we need to track both. We need to be mindful of both. The guideline offers a lot of really good information about systolic targets, diastolic targets, and why the 2017 ACC/AHA guideline is an excellent resource there. But that's a really good question, Allison. Thank you.
Right, thank you. Next, let me double check she's still up. Rosa Annabella Tavares, you have a couple of questions in the chat, so I'm going to allow you to talk, of course, and please come off mute so you can ask the question directly.
Okay, I'm going to just look at the questions I had, because I did have several. Well, one of the questions I had was the challenges in terms of dealing with patients who have no literacy. So we're not talking about health literacy, just literacy in general. And how do you help them with correct medication identification? Because that's often a barrier for correct usage. How do you help them with self-blood pressure monitoring control and visit compliance? And are there any initiatives or anything out there specifically targeting those patients? That's the first question.
Yeah, I think that's a really great question, and that poses, it's a significant challenge. And I don't know that there's any clear, straightforward answer for the best way to deal with that. But I will say that I've seen some great examples leveraging community health workers who can spend more time in person and especially in the home, helping people understand for home blood pressure monitoring, for example, for self-measured blood pressure monitoring, to talk about device use. There are certainly with time invested in helping people accurately self-measure, it's going to take a lot more time than maybe available in a clinical setting or even a group setting. And so leveraging other members of the healthcare team, we've seen pharmacists do a great job with this. We've seen community health workers do a great job with this. And regarding the medication specifically, pharmacists really are the best resources that we've seen for this, for trying to help in different ways. But it's extremely challenging. It's a huge problem. And I don't know that there are any great answers there, which is why it continues to be a problem. But we always try to collaborate with pharmacists here who have really more touches with patients than most clinicians do in clinical settings. And again, leveraging community health workers for the same reason. So we've just got to do a better job at being able to have access to these really great resources. And I know it's not currently adequate. I know it's being studied, but we need to do more.
And then the other combined questions was on the combination suggestions. Anecdotally, I find that adding like a diuretic or an ACE seems to have better added benefit as far as lowering the blood pressure than calcium channel blockers or betas. But is there actual evidence as far as if you're going to do the combo, which is the best combo as far as maximum blood pressure lowering? And then kind of piggybacking off of that is that frequently, even if somebody has elevated blood pressures and the guidelines may suggest starting with a combo, there's often a lot of patient resistance to being over medicated, especially if that's their initial diagnosis of hypertension. So again, is there some suggestions or pearls to trying to get patients on board and providers on board? Because I think that's also the tension that providers may bring into that, is how do you negotiate that?
More. Yeah, I couldn't agree more. But I'll start. So I'm going to try to remember all three of these. As far as what's the best combination, I think there have been some studies that have looked at starting with different combinations, and ACE calcium channel blocker combinations seem to be extremely effective with the reduction in mortality across large populations, large percentages of populations being studied. And I think probably one of the reasons that we like to go with the calcium channel blocker ACE or ARB combination, so calcium channel blocker RAS blocker combo, they're usually very well tolerated. The ACE tends to counteract some of the effects of edema from being on a calcium channel blocker. But I think probably the most important benefit in my mind is the ability to then add a thiazide-like diuretic. The guidelines, when diuretics are recommended in most guidelines around the world, most of us tend to use hydrochlorothiazide, but those recommendations are specifically for thiazide-like diuretics like indapamide and chlorthalidone. And while those drugs are just not available as frequently in the United States, so most end up using hydrochlorothiazide, which is really a BID drug. It's much less potent at the way that we typically use it at 12.5 or 25 milligrams, which is considered a lower dose on the spectrum. Drugs like indapamide and chlorthalidone tend to last 24 to 36 hours. So literally you could miss a dose and they would typically, you'd have a much longer period of time that people are protected. So yes, so CCBs and ACEs are really preferred in many situations as the first combination in, and then adding a potent, long-acting thiazide-like diuretic. I think that's a very good combination, and that will get a large majority of people to goal. And then the fourth drug in there would be, spironolactone. And those four drug classes used together can get almost between 80 and 90% of people to goal, and the rest, closer to 90 actually, and the rest will be resistant and, need referral and help there. But I know you're familiar with all these things, but from my read of the literature and talking to other hypertension experts, I think many would agree to that. Now, hydrochlorothiazide is a very effective drug. It's the one that's available in all of our combinations. And so we do see some switching around of medications when they're started. Based on whether people, it's always better to use less pills if you can get people to goal. So I'll stop there for the first question. The second question, I think, was more around that shared decision and the idea of using combination therapy to start may not be well liked by patients. From our experience, and and looking at this, I think there's more there is patient resistance for sure, but because they're taking one pill, many patients, if providers are on board with using two medications in a single pill, for patients, it's taking one pill. And we're seeing a lot more low dose combination pills that have lower side effects, and very easy to use. I mean, I think availability is a factor, formulary is a factor, but there are a lot more combination therapy, 2 and 3 drug combination pills on formularies, including 340B at health centers. It varies by state on Medicaid formularies and 340B formularies, but we find that a lot of providers tell us that they don't have access, and then we'll actually pull up their formularies and they're just not familiar with what's there. That is extremely common. But as far as getting patients to agree to take combination therapy, because they're not likely to see more discontinuation due to adverse effects starting 2 drugs over 1 drug, and they're much more likely to get to goal quicker taking a combination in a single pill like that and have better outcomes. I think talking up the outcomes in that slide that I show on outcomes is extremely important. If you can tell somebody that if I start you on 2 medications compared to 1 medication, you'll have less heart attack, less heart failure, and less death, less risk of dying compared to if I start you on 1 medication. I think that's pretty motivating for people. And we've seen people using that kind of decision and education at the time of prescribing be very effective. But I don't think it's commonly used. I don't think people realize not only will you get to go quicker and improve adherence, make things easier for them, that you'll also improve outcomes. And patients want to get to goal. That's another thing that I haven't really mentioned yet today that I think is important, is that patients tend to get discouraged if they don't get their blood pressure under control in the first couple of months. So you've really got an important early window there to try to get people to goal quickly before they really get discouraged. And if, with combination therapy, you're much more likely to do that quickly in the first few months. And this is why there's really been a push for many reasons to get 3-drug and even 4-drug very low dose combinations to market. There are 2 pending that will likely come out in the next 1 to 2 years that are being, going through trials now that have been studied extensively, but now they need to go through trials in the United States. And the very low dose combinations are extremely effective getting people to goal. They don't often need to be titrated. If with the first prescription, between 70 and 80% of people can get to goal in the first year. And that, I think we need to hopefully move towards that. They're taking 1 pill, 3 or 4 very low doses of medications, different medications, very well tolerated, and 80% get to goal within a year. I think that's a great way to go. And you don't have to titrate the medications. Patients prefer that. Again, no more discontinuation due to adverse events than if you're using monotherapy, which as you titrate up, you tend to see more side effects. So long answer again to your question. They're really good questions though. And I think these providers grapple with these concerns all the time. It's just extremely common. And I don't think there's any one easy answer, but we need to do a better job communicating when we make these shared decisions to make sure that we get all the information out there. And I agree with you that I think sometimes this is more a barrier with providers making these recommendations because of their concern about patient intolerance than it is for patients actually saying, no, I'm not going to take this single pill that you're prescribing me because it has 2 medications instead of 1. I really think it's how it's framed and how it's discussed.
Dr. Breakout, thank you. I think a good closing question for us is, where can we find treatment protocols to use at our organization?
Yeah, and so I said, so there are many protocols available. The Million Hearts website is a great place to go to find 3 or 4 well-used protocols from, whether it's from, an AMA protocol or a CDC AHA combination protocol, or the Kaiser protocols available there, the VA protocols available there. So some excellent protocols. But I'll say what I said earlier that I think is really important, that if providers and physicians and other providers at an organization can contribute to making that protocol, they're much more likely to use it. So it rather than bring in an outside protocol that you think it's going to work, you'll see a lot of disagreement from providers on based on what they do or what they don't do. But if you get them into a room and collaborate with a pharmacist to come up with a mutually agreed upon protocol for an entire organization, I think there's much better adoption of that protocol. And we've seen that time and time again. And then embedding that protocol, making it easy to use so people don't have to go looking for a piece of paper or even a PDF. If you can embed that into an EMR, have it available with sort of what's the next intensification move already pre-populated in an order set, so that providers can still have a lot of choice there, but the pre-populated lists for orders, I mean, that's been shown to really impact prescribing behavior if it's embedded. So for all of those reasons, I think those are places to go to get protocols if you need to, but I highly recommend, if at all possible, to try to create one within your organization and have it be an organizational priority.
Very good. Thank you. Thank you, Dr. Breakout, and to all the attendees for the good discussion. Our next breakout session will start at 10. You should already have a link for that session. If not, you can always head back to the main room for help. Otherwise, please take a moment, get up, get out of the chair, stretch, maybe get some water, and head to your next session. And Dr. Breakout, thank you again for lending your expertise and talents to us today.
And thank you. Thank you, everyone, for attending. Really appreciate it.